Welcome to the Independent Sage Friday briefing. The vaccine programme had been going so brilliantly, but has hit a stumbling block this week as it's been announced that the rollout to people under 50 in the UK will be delayed by a month. The Health Secretary has also ruled out easing restrictions for vaccinated people, saying that we lift measures for all groups all at once. It's sobering to reflect now that it's a whole year since COVID-19 came into our lives. We're now just a few days away from the anniversary of when Britain first went into lockdown. And there are clearly still significant challenges ahead and a real need to engage with the data, not dates strategy, the strategy that Independent Sage has been calling for. Before we get into questions, we always start with an overview of the latest facts and figures, and Professor Christina Pargle has them at her fingertips. Over to you, Christina.
Hi everyone, let me just share my screen. So I hope you guys can see that. So yeah, it's a mixed week this week. So there's some good news, but there's also some less good news. And I'm going to kind of talk about cases very briefly, hospitalizations and death, and then dig in a bit more into vaccinations and schools and the European picture. So cases first. So you can see over the whole of the UK, the last couple of weeks is now basically completely flat, kind of pancake-like. If we look at it by each of the UK nations, you can see this kind of is the case for all of them here. Scotland and Northern Ireland now have the highest case rates, and Scotland has never been in that situation. Scotland's always kind of been one of the lower nations. And apart from England, testing in each nation has been really flat over the last few months. So it's not about increases in testing that's causing this. In England, it might be because there was a massive increase in testing when schools went back. The Office of National Statistics, their infection survey, which they released today, which goes up to the 13th of March, kind of shows a similar picture as the case rate. So England and Wales are still kind of going down. Wales is starting to level off. Northern Ireland is pretty flat. And actually, ONS said that in Scotland, there is now signs that the percentage of people testing positive has gone up over the last week, which is obviously a little concerning. If we look at English regions now, again, this is up to the 13th of March by date of test, and look at positivity rates, you can see that they are also flat and flatter in the North and the Midlands, which have the higher rates, and Yorkshire and the Humber is now the highest rate for positivity and cases in England. And again, this is consistent with the ONS infection survey, except that the infection survey also says that the East Midlands seems to be increasing with its cases. So that's also something to watch out for. There are many ONS surveys, and there was another one that kind of looks at behavior every week and people's attitudes to COVID. And what that has shown, that over the last week, more people have gone out to work, more people have left home for non-essential shopping, to take kids to school, to meet up in a public space. So people are kind of starting to get out and about more. But protective behaviour, so like wearing a mask, hand washing, social distancing, they have remained really high. They're all like in the 90%. Hospitalizations and deaths, well, these are still coming down steeply in all nations. That's a really good thing. Obviously, it's not unexpected because they reflect cases a few weeks ago, and cases a few weeks ago were coming down steeply. So this will probably continue next week, but we will start seeing this flatten off because cases have recently flattened off. So vaccination data now. So this week has seen an increase in the number. We vaccinated over 3 million people, received a jab in the weeks of the 17th of March. You can see in the orange that we're now giving many more second doses, mainly to the over 80s now. And there's also been reports this week that there's going to be a slowdown in rolling out vaccinations to the under 50s, which are the next group. And that's basically because you can see here that in January and early February, there are about 11 to 12 million people who got their first dose, and they're coming up to their 12-week interval. So they absolutely need to get their second dose by the end of April. That's kind of non-negotiable. And what that means is that if you haven't increased your supply to over, like we've been doing 2 to 3 million people a week, if we haven't got more than that, then pretty much all of it has to go on second doses for the next month. So that's why there is going to be a slowdown. And originally they'd hoped to increase supply in April so they could keep vaccinating people with their first jab as well as honouring the second doses. Now that doesn't look like it's going to happen. And you can't really start giving first doses again until we increase our supply, which hopefully it seems like will be in May onwards. Now, this means that we're effectively back on the original schedule that the government laid out to offer everyone a first jab some point in July, and not the kind of accelerated schedule that people were thinking of. So if we're looking at coverage, I've now kind of changed this graph a bit because you can see kind of where we want to go. So this is where we started. We want to end up over here at kind of as close to 100% of people offered to have taken both their doses eventually. And this is kind of July, which is the current timetable. So what I expect to see over April, if there is this slowdown, is that this will now flatten off, and it will flatten off for a few weeks until we can increase supply and start offering first doses while still honouring second doses. We also have updated information about vaccine impact. So this is really good news. This is from Public Health England, released it this week. And they specifically looked at impact in the over 80s because that's the group that got it first. So we have a lot more data about what happened to them. So I just want to kind of show you what that impact is. So if we assume that there are 100,000 over 80s who haven't had the vaccine and 100,000 who have. So in those who haven't had it, you might expect maybe 300 might get COVID. Now, the exact number will depend on the state of the epidemic. So this is kind of an illustrative number. But let's say 300 get it. Out of those, about 45 might need hospital and about 40 might die. And this reflects the fact that the over 80s are the most vulnerable group for COVID. So if you've been vaccinated, this is one dose, it offers you about 60% protection. After 2 weeks, for the first 2 weeks after your vaccination, you don't have any extra protection. So it's still really important to be really careful. But after 2 weeks, there's about a 60% reduction. So out of the 100,000, 120 people might get COVID. And that reflects the fact that you have some protection. Now you get additional protection, they found, that if you do get COVID, symptomatic COVID, you're still less likely to need hospital. So you have another about 40% reduction in risk of needing hospital. So out of that 100,000 people, only 10 people might need hospital for COVID. So that's overall about an 80% reduction. And again, you have an even bigger reduction in death. So it gives you extra protection against death. That's about a 55% reduction. So out of that 100,000 people, only 7 might die compared to 40 in the unvaccinated group. So that's about 85% reduction. So this is really good news. So it's not, it's not perfect, but it offers you massive protection, even just one dose. And that protection is higher in younger people, and it will get even higher after the second dose. But in a way, it's a bit like seatbelts and car safety and airbags. They give you and make it about 80% less likely for you to die if you're in a car accident. And that means you really want to wear a seatbelt and you want a safe car and you want airbags, but it doesn't mean that you would then drive crazily, right? You still want to drive safely. So I think that's kind of what we want to think with vaccines. They're really, really good, but you still want to carry on with the kind of protective behaviors that we've been doing over the last year. So now thinking about schools. So I'm going to start with Scotland, because in Scotland, primary schools did a phased return from the 22nd of February, which is now a few weeks ago. And I just want to start with just looking at the number of tests taken in Scotland. So when primary schools went back, it wasn't all years of primary school, and they put in various mitigations in place. And there's no asymptomatic testing of primary school children in Scotland. And teachers and school staff can take lateral flow device tests, that they don't need to, and all lateral flow device tests in Scotland, if you have a positive result, you get a confirmatory PCR. But you can see that actually testing hasn't gone up since schools opened. So when you see changes in case numbers, it's probably not because of more testing. So let's just have a look and see what happened to the number of positive cases by age group in Scotland. And I'm doing under 65s to be kind of the unvaccinated population. And this is people who would have had symptoms and so sought testing that way. So what you can see is that for children under 14, since primary schools went back, there was like nothing really happened for a week, and then cases have started going up since then. There's also this increase in mid-February that I don't know what that was, but there is definitely, does seem to be a sustained increase in the week after school started going back. And remember that this is a 0 to 14 year age bracket, and actually it's only a smaller age bracket that went back to school. In the other age groups, you don't see that increase, but you do see a flattening off, right? So cases have stopped falling, and there's some very, very preliminary indication that for the 15 to 24-year-olds and 25 to 44-year-olds, the cases are starting to creep up now. And, you know, it's too early to say what that is. It's too early to say whether it's school children getting it and then potentially passing it on to their parents and their siblings. But, you know, if that was the case, it wouldn't necessarily be surprising. And it does mean that we do have to be quite careful to kind of keep track of what's happening over the next 2 weeks. And it's kind of a shame that in Scotland there isn't any kind of testing of asymptomatic children. They don't have, like the ONS, but the ONS survey doesn't break results down by age group. So we can't really look at it that way. So, and as of the 8th of March, more primary school kids went back. And as of this week, secondary school kids have gone back in Scotland. So in England, the number of tests each day, you can see when schools went back, have shot up by about 1 million a day. That's the lateral flow device test that secondary school students had to do 3 tests of at school over the last 10 days. And those tests did not get confirmatory PCR testing if someone tested positive. And we saw cases flatten in England. Now, I think a lot of that flattening originally is from doing all these extra lateral flow device tests, because if we look at just cases that were confirmed by PCR testing, you do still see a week-on-week drop over last week. This only goes up to the 13th of March because this data is only available by date of test. And so this is still dropping, and that kind of dropped week on week by 8%, whereas overall cases in England dropped by 2%. So it does seem as if doing all those extra lateral flow device tests has kind of inflated our case numbers a bit over the last 10 days. But so although for PCR testing, you have to kind of wait a few days to get the results by date of test. So this can only go up to the 13th of March. For lateral flow device tests, because they're pretty much instantaneous, those results get uploaded the same day. So if you get a positive from a lateral flow device test that doesn't need PCR testing, because the government says you don't need it if you take it at school, then we can look at much more recent data. So we can look at Monday, Tuesday, Wednesday of this week. And when we do that, you can see that this week, the number of positives has almost doubled. But the number of tests hasn't. So, you know, who knows what that is? I mean, it could be, and it might well be, that there has been some transmission over the past week. We don't have confirmatory testing of PCR, so some of this will be false positives, but because the number of tests hasn't changed, that can't be the only reason for this increase. So this is kind of an early indication that there might be something going on, but it's very preliminary and the numbers are still very small. And the problem with these kind of lateral flow device tests is you can't really look at positivity rates. That's because people are taking the tests multiple times. So each student should have taken maybe 3 tests over the last 10 days if they didn't test positive. And so you can't really just look at number of tests and then divide it, and then divide the number of positives by the number of tests. It doesn't work. Also, the only people who should be taking lateral flow device tests are people without symptoms. And we don't really know how many of those there are. So that's the other issue. We don't really know what to expect out of a positivity rate. And there's also differences in whether you get a confirmatory PCR test. And the problem with lateral flow device tests, they will miss true positives. So they will miss some people who do have COVID. And they also give some false positives. And again, so it does make the positivity rates quite hard to interpret. And from this week onwards, lateral flow device tests for school children and staff will be done at home. And what that means is that it's likely there'll be more false negatives. So that means they're more likely to miss real cases. And that's because it's quite hard to do a lateral flow test. And so it's quite easy just to get the wrong bit of your throat or your nose for the sample, and then it will test negative even if you do have it. So we kind of expect more false negatives. But because you do get confirmatory PCR tests now, you'll have fewer false positives. That's a really good thing. But it will change your case numbers. Also, all testing is voluntary, and I will have no idea how many people will actually keep doing this test week on week at home. So the case numbers will be really different for the next few weeks. So it's going to be really hard to keep track of what's happening in schools. It's going to be really, really difficult. So we're kind of reliant on ONS testing. And the survey that came out today showed that cases are decreasing in all age groups except primary school children. So that's kind of an early indication that there is perhaps unsurprisingly, some transmission happening in primary schools. So just kind of finishing off with the European picture and a little bit of discussion on variants. These are just 8 countries, including the UK. Here you can see our big January spike. The main thing that's happened is that over this year, the B117 strain, which is the Kent variant that we have in England now, and like over 98% of our cases are now this variant, has spread across Europe and is most of the cases in pretty much every European country. And as it's taken over, cases have started going up again. Differently in each country, but certainly a pattern. And all of these countries are now putting in more restrictions, trying to do their best to kind of keep cases down. And if we look at European vaccination, you can see that the percentage of population who've received at least one dose, the UK is obviously doing pretty well on that. Other European countries are significantly further behind. If we look at the percentage of fully vaccinated people, again, nowhere has got very far with that. So I do think we have to just not be complacent, even in the UK, about our vaccination program, and that somehow that makes everything okay now, because it doesn't. And the other thing that's been happening over the last month is that there are more and more new variants being discovered in Europe, in England, in America. There's a California strain that's kind of battling out the Kent strain in the US. It's also more infectious. It also has some concerning mutations that might affect vaccines. There's been a new variant discovered in France that isn't detected in standard tests. If that does start spreading, that's going to be a problem because we haven't got a way of tracking it. And there's a new variant coming out in the Philippines. So, there are a lot of new variants coming out. And this is going to be kind of, I think, a feature of the summer as we're trying to vaccinate our populations. Public Health England is tracking various variants in England. And this is its latest report released, I think, yesterday. And what you can see here is that there are more and more cases of the South Africa variant, which is concerning. I mean, it's still not that many. It's still, it's certainly nowhere near dominant. It's probably less than 1% of cases, if that. But the fact that it is spreading is worrying, especially as we're opening up, because some of the vaccines work less well with the South African variant. So we have to be worried about this. There's this new variant called B1525, which I know very little about, except that it shares some of the mutations with the South African variant that might make vaccines work less well. And then there's another new variant that seems to be increasing slightly here, which I literally know nothing about. And Public Health England don't even know where it's from. So just to summarize then, hospitalizations and deaths are still falling, but cases are flat or going up. Vaccination is going well, And there is a clear positive impact from the first dose, and that's really, really good news. And actually, what I forgot to say is that the effectiveness of AstraZeneca and Pfizer on the variants that we have here are exactly the same. AstraZeneca works just as well as Pfizer in it, and that's really good news. We do now have to start doing mass second doses, and that will slow down rollout to the under 50s until we can increase supply significantly. And hopefully that'll be as soon as possible, but definitely hopefully by May. There is some indication, preliminary indication, that returning to school is increasing cases in children. We will need to watch for the next 2 weeks very carefully to see if that continues, and then whether it spreads to older age groups, particularly as we're now not necessarily vaccinating the under 50s for at least a few more weeks. In England, the testing system, the way they've done testing in schools, makes it very difficult for us to know what would be going on in schools over the next few weeks. The situation in Europe is concerning, but the countries are responding, and they are responding a bit earlier than we did, and hopefully that will reduce the size of any third wave. And there are new and potentially concerning variants popping up every few weeks, so it's not just the case of we've got the Kent strain, we do have to worry about other strains. And just finally, before just kind of passing on to Sir Dave King, as we reflect on the year that's just happened, we really do need to learn from it so that we're still not here next March. That I do not want to be giving these briefings next March. I want us to be able to have a way out of this pandemic. There is a way out, but it can't be taken for granted, and we can't be complacent. And I will end on that.
Thank you very much, Christina. And as Christina said, Sir David King, the chair of Independent Sage, is now going to say a few words. Over to you, Sir David.
Thank you very much, Alice. Well, we are 1 year in since we went into our first lockdown in the United Kingdom, in England. And what we have is the ability to congratulate government on the terrific rollout of vaccines, and that you've just heard Christina spell out may not continue at the present rate, will not continue, because second vaccines for each individual are really important, and that is going to probably use up the supply for a while. But nevertheless, it has been a very successful rollout. But what we would like to stress is the avoidance of complacency over a reliance on vaccines. So we do need to avoid a fourth wave. And a fourth wave is a possibility, particularly with the emergence of new forms of the virus in different parts of the world. What we would like to enforce with the government is the notion of a systematic, comprehensive suppression strategy to drive down levels of infection and the density of virus in the country. We will only see mutations again in this country if we retain a high level of virus in the country. And so we return to focusing on a locally based find, test, trace, isolate, and support system. And that support system really also means checking that people are in isolation. We know that the success rate of isolation has never been close to where it should be. And so we need a real focus from government to drive the level of the disease down in this country and not assume that vaccination is going to do it for us. We can already see that in the figures that Christina has just given. We're seeing flattening out of the number of cases per day. And that means we still have around 6,000 cases a day in our region of the world. Let me just move on to prioritizing. For government, please note, we need to prioritize local support for communities in deprived areas. And we have been rattling on about this for some time, but the government really needs to recognize that in deprived areas, the disease continues at a higher level than in other parts of the country. And we need to see that support goes into those people who need support in those deprived areas. We strongly back the call for a public inquiry as soon as possible, certainly by June, to ensure that lessons are learned. We have so far in excess of 125,000 reported deaths from COVID-19. We have a very much larger number of people with long COVID. These are people whose lifespan is going to be significantly reduced by having had COVID. And we also know that the economy has been very badly hit by this whole episode. All of this could, we believe, have been avoided with a proper procedure to isolate those with the disease from those who are healthy. If that had been put in place very early on, then an enormous saving to the country in terms of deaths and finance would have occurred. We need to see that the lessons are learned and learned quickly. Thank you.
Thank you very much, Sir David. And now we're going to open up to questions, and I want to get through as many as possible. So I would ask you please to keep your questions as concise as you possibly can. And I know all the scientists on the panel are always very concise and precise. The first question comes from political commentator Femi Olawole. Femi, what's your question?
Unmuting first and starting video. There we go. Hi. My question is, yes, we have the vaccine shortage issue, which means we're going to struggle to get first doses to continue at the same rate as they have done thus far. But what would you say to the concept of answering the issue around this becoming a disease of the disadvantaged by prioritizing the vaccination of those in lower tax brackets, using HMRC's data to achieve that, by essentially putting those in the highest tax bracket at the end, especially as there are studies which show that once you get down to those lower ages, it becomes more valuable to vaccinate those at the most risk of spreading the disease than simply by age alone.
Femi, thank you very much for a really interesting question. I wonder if Dr. Zubaida Haque, you'd like to start with this one.
Thank you, Femi. This is a really important question, and we've tried to address this time and time again, because what's interesting about the vaccination program is when it started off, it was very much about those who were the most at risk and the most vulnerable, which is why, of course, we started off with the over 80s, as we should have. I think what's deeply worrying and concerning is at some stage that's now changed, and we've been given the argument by JCVI and others that this is because speed is of the essence, as though there's proof that actually as though there's proof that if you speed things up, that you can't also vaccinate vulnerable groups in deprived areas, vulnerable groups in lower incomes, and vulnerable groups in terms of Black and ethnic minority people. And we have a situation now, Femi, where not only have some Asian groups have been more likely to die and be hospitalized in the second wave, but we also know that we still have a situation where people from deprived areas are 2 times more at risk of dying than their more advantaged counterparts. So there is a really strong argument for prioritizing vaccination, and it's not clear. The argument that it compromises speed, evidence hasn't been shown, and it's not clear, and I think we need to revisit it, just as you've suggested.
Thank you very much, Zubaida. And I think Professor Gabriel Scally, you want to comment here?
I think it's a really interesting point, and I agree with you, Femi, that something should be done. The UK has been very conservative in terms of its prioritization process, and quite a few other countries have taken a different approach. For example, in the United States, quite a few states have prioritized, for example, transit workers, transport workers, have people working in food stores, those who are likely to come into face-to-face contact. In fact, Joe Biden has said that he wants to see all teachers having their first dose of the vaccine by the end of March because of their role. So I think there is a good case for looking at the situation. And I worry about the completeness of our vaccination programs at the moment, even amongst the most elderly and the most vulnerable, because we know that the rates are lowest in some of our most deprived communities. So I would absolutely favour putting particular effort into places where which are most likely to harbour ongoing endemic disease. And we know where those are because we learnt about that at the end of the first lockdown, when there were a series of local authorities, particularly in the Greater Manchester area, where there were three key factors: the high level of deprivation, a high level of overcrowding, and a high level proportion of people from BME backgrounds. And we should be looking urgently, I think, at making sure that our vaccine programs are as comprehensive in those areas as they are in any other area in the country. So I'm not so sure about using HMRC. I think one of the things that would be really potent is community effort to do this, particularly making use of existing community structures and faith organizations. And that's more likely to be able to be done on a community and a neighborhood basis, rather than anything to do with a code for their earnings. But it is a really important question that isn't being discussed or probed the way you're asking us today. Thanks for the question.
Yes, thank you very much, Femi, and thank you for those responses, Gabriel and Zubaida. The next question comes from Jeffrey Strang. Jeffrey, are you with us?
Yes, I am. Thank you very much. I'm a retired Director of Public Health and Medical Director. To successfully come out of this pandemic, we need strategic thinkers, and we certainly need completers and finishers. And you have constantly, at each of your meetings, discussed and made a plea for the completing, finishing elements of the management of the pandemic to be reinforced. Schools, workplaces, what's going to happen when they open up indoor hospitality in the coming weeks. My first question is really been answered partly by Sir David King, and it's really about the extent to which Independent Sage thinks there is a real risk of unravelling of the pandemic, given that the cases have levelled off, and that if there is an unravelling at some time later in the year, it's going to affect most severely our most deprived communities. And secondly, having listened to the Prime Minister yesterday at the press briefing about monitoring the progress and to judge whether it's safe to proceed through all 4 steps of the roadmap based on the government's 4 steps. The Prime Minister was very clear that even though the vaccine rollout may be a little bit of a hiccup in the next 4 weeks, as you've already discussed this afternoon, he could see that all 4 steps of the getting out of the pandemic would go ahead basically on the dates as specified. And it was interesting that the CMO qualified this by saying we need to look at the data. My plea to Indy Sage is that there's really a much needed critical second opinion, and I certainly, as an ex-professional, would look to Indy Sage to provide that independent assessment at each stage of the milestones, because I have some reservations as to the rigour in terms of how the government is going to handle this at each of the ends of the period, the dates that have been defined as being review dates. Thank you.
Thank you very much for your question. And Professor Susan Mickey, you'd like to respond first.
Yep, thank you for the question. The phrase looking at the data is very general, rather like following the science. It doesn't really in itself mean anything. And what hasn't been spelt out is what would it take not to change things as per each of those milestones. We've never been told that. We've never been told what the thresholds are of what, and if some thresholds were to be passed, what would then be done about it? So I think we all have to keep asking questions, because the problem about having rolled out this roadmap or put it in front of everybody's eyes with an emphasis actually on the dates rather than the data, despite what the mantra was, is that politically it's going to be difficult for this government to roll back. And we've seen what the problem has been over this last year by political expedience taking precedence over public health concern and strategy. So I think it's something we all have to keep asking, keep a really clear eye on what's happening, and really actively push for measures as we think they need to be used.
Thank you, Susan. I can see that Professor Stephen Reischer would like to respond too.
I would, when I can unmute myself. One of the themes of today, a year on, is to learn from what's happened over the last year and learning from our mistakes. And one of the clearest mistakes, I think, last summer was opening too quickly and giving the implicit message that things were all over, that people could go back to pubs, they could go back to work, they could mix, and everything would be okay. And of course, part of the consequence of that was a spike in infections and has been the second and third waves and all the misery we've seen recently. And I fear that the same thing is happening now, because the problem is that if you give absolute set dates, and if you start talking in terms of what will happen on particular dates, then you give the public the impression that this is inevitable, and that it's basically all over bar the shouting. And the problem then, again, is that people begin to see lowered risk, and there's some evidence that that's happening. And because they see lowered risk, they see little point in the mitigations. And so complacency creeps in a major way. And the great paradox, of course, is the more that you say that something will happen, the more you change behaviors in such a way that it is less likely to happen. And I think we've got to stop talking in terms of dates. I think the media, as well as the government, have got to stop talking about dates when things will happen. And we need to think much more in terms of points of review, that the set dates are points where we see where we are and whether it's safe to reopen, and what's happening to the level of infections, and what's happening to the R rate and so on. And we've all got to be involved in making that happen, because to the extent that you make the reopening contingent, then you say to the public, well, it is contingent upon what you do. It's also contingent on what the government does, but it's a contingent upon what the public does. You enlist the public, you make the public active, you make the public agentic, you give them a sense of self-efficacy and being partners in the fight against the pandemic. And it's only as a partnership between government and public will overcome this. And the real danger is that the government, in trying to reassure the public, is rendering the public passive and rendering the public complacent, and therefore making it less likely that we're going to be able to meet those dates. So I think there needs to be a fundamental change in the messaging, and a fundamental message that nothing is inevitable. We've got to work to make this happen. We can make this happen, but we do have to work at it.
Thank you very much, Stephen. And of course, the other part of Jeffrey's question was, will Independent Sage put their view forward at those critical times when we know that those dates are there in the roadmap, but as you say, Stephen, they should be there for review. Independent Sage has previously produced reports in good time at various points during the pandemic in relation to the government strategy. Will it continue to do that? Susan's putting her thumb up. So David, do you think this is an important aspect of what Independent Sage does at the moment to review this roadmap?
It's a very important, I think your question is really very pertinent. And where we can, I think we should put out papers to state how we feel the situation is when we come to these critical points. I really hope that we can do that. It is quite an onerous task for us, but my colleagues have already shown that they're pretty hardworking. So thank you for the question.
Thank you very much. Thank you, Jeffrey. Thank you, Sir David. Moving on to our next questioner now, who is Louise Smart from the East Midlands. Louise, are you here with your question? Silence. No, she's there. Hello.
Hi, yes, I'm here. Thanks ever so much for giving me the opportunity to ask a question today. I really appreciate that. Mine is around my mum and her clinically extremely vulnerable husband, who are both in their 80s, had their booster booked at the time of their first jab. And at the vaccination centre, they emphasised greatly to them that they must have their jab on that date that they had booked. However, it was cancelled the week of the jab, the second jab. So my question is, what are the implications of waiting more than 12 weeks from your first jab to your booster to complete the programme of vaccination, please?
Thank you very much, Louise. Now, our resident virologist, Dean Pillay, had to leave, so I'm going to have to pick on somebody else to answer this question, but there is plenty of expertise on the panel here. I'm looking at you, Gabriel. Yes, Professor Gabriel Scally.
Yeah, I'm a public health physician rather than a virologist or a vaccinologist, but one of the points to understand is that we don't really know the answer to some of those questions because we haven't been through this process yet, and we simply don't know. But building on what we do know about the immune response in the 12-week period, so there's every chance that the second dose of the vaccine will continue to have some effect. It won't just stop being effective if it's 12 weeks and 1 day or 12 weeks and 2 days or whatever, but there will be, one would expect, a tail off over time. But that is not the major concern that you have, I'm sure. It's about getting them their second dose. And I think that's the problem of going over the 12 weeks is something you really need to contact your general practice or the relevant general practice and discuss it with them so that they can make sure that they do get their second dose as soon as they possibly can, because that is the schedule, and that's the schedule we should be trying very hard to stick to.
Thank you very much, Gabriel. Does anybody else want to respond to this one? It seems like a fairly definite answer there, Louise.
Yeah, thank you.
There shouldn't be much delay. So I hope that you're successful in getting those vaccinations done.
Very much.
The next question comes from Steve Roderick. Steve, are you with us?
Yes, I am. Thank you. Thank you very much. So here we are 1 year on, and I would like to know, why is there still no proper border control? Why isn't isolation on entry to the UK mandatory with no exceptions and managed to ensure compliance? And as a rider, should the managed isolation be paid for by the government? Thank you.
Thank you very much, Steve. We have covered this before on Independence Age. Gabriel normally talks at length about this, but I'm not going to let him speak because he's just spoken. So I wonder if, Susan, you could take this one.
Well, what we have never had from the government is a comprehensive overall strategy that includes a find, test, trace, and isolate system, and that includes sufficient border controls. What's happened is responses to pretty desperate situations, often when it's a bit late, and not learning the lessons of what's happened in the rest of the world. And this has been something that's been a feature all the time. And I think after a year, and actually it's rather more than a year, if you think about when the government should have first acted on this, is to start really looking at the other countries that have done this well and getting good border controls in place and ensuring that the investment is put in to making them work properly pays for itself many times over in terms of preventing the variants and the transmission rates going up. Similarly, with the support for isolation, which other countries do, both in terms of visiting daily, offering practical support, and in terms of paying people to stay at home where they need financial support to stay at home, and also offering alternative accommodation locally where they can't isolate at home. And indeed, many people, probably most people in this country, haven't got houses of the size that means you can isolate successfully at home. Now, you said, should the government be paying for that? We're actually paying, aren't we? You know, it's our taxes that are being used for the whole pandemic response. And first of all, one of the things we've said all the way along is that there should be much more consultation with the public, much more listening to the public. And I think the strategy would be much better if they did do that. And I think they should start doing that now. And, secondly, put the investment where other countries have shown that investment is wisely spent, and border controls and support for isolation are definitely very high up on the priority list, if not the two top items on the priority list. Thanks.
Thank you very much, Susan. I know that Professor Christina Pargle, you were thinking about responding to this as well.
Yeah, just to say that I don't understand why they're not putting in stronger border measures, because the single biggest risk to the vaccination program here is new variants coming in that will resist our vaccines. And the government has bet pretty much this entire strategy on vaccination. We think it could have done a lot more, but that's what it's betting on. So given that, the fact that they're not kind of closing the door to new variants from elsewhere, which we can see popping up all the time, as well as keeping cases down here to prevent more being grown here, is just inexplicable to me, to be honest. I just don't understand why they're prepared to risk it.
Thank you very much, Christina. Kit, you've had your hand up for a while. Dr. Kit Yates.
Thanks, Alice. This issue of being 1 year on and what have we done? The really frustrating thing for me is when Boris Johnson came out when we hit the 100,000 deaths milestone, and he said, we've truly done everything we can to minimise suffering and to minimise the loss of life. And honestly, to me, that strikes me as someone who doesn't think that they're culpable for any of the mistakes and doesn't think that there's any lessons to be learned. And for me, that seems like an insult to the families of people who've lost loved ones over the year, the 140,000 people. To hear him say, we did everything we could. Well, delaying lockdown in the autumn for 6 weeks wasn't doing everything that we could. When we learned about this new, more transmissible B117 variant in the UK in December, waiting to lock down until January the 4th across the whole country wasn't doing everything that we could. Sending kids back to school for a single day wasn't doing everything that we could. Gaslighting the public by backing Dominic Cummings when he clearly broke lockdown rules, that wasn't doing everything that we could. And saying that we're going to throw a protective ring around care homes and then sending people back from hospital without having a negative test, that obviously wasn't doing everything we could. And borders is yet another example of that happening. We have risk of new variants coming into the country, which will potentially negate our great efforts on our vaccination program. We've been fortunate at the moment that the reproductive number is less than 1, which means that naturally new variants coming into the country, those chains of transmission will be broken. But as we start to open things up, that won't be the case anymore. And, there's a red list of countries which we are worried about variants coming in from. But actually, there are plenty of countries where those variants are spreading at the moment, and they're not on our red list at the moment. So France has, for example, has high levels of some of these variants, and we're not doing anything to stop that. And mandatory isolation for everyone coming into the country is one way, as we've seen in Australia, as we've seen in New Zealand and other countries, that we can tackle that. So personally, I think that we need to be doing more on borders.
Thank you very much, Kit. And Stephen Reischer.
Hey, we all know that old saying that if you think that education is expensive, just think about the costs of ignorance. So we've just heard from Christina that we're paying vast amounts of the vaccines, and yet we endanger all of that by not getting people to quarantine when they come into this country. And equally, we're paying £37 billion for the test and trace system, and yet we endanger all of that. And we run the risk of wasting all of that by not paying people to self-isolate. So if the government thinks that it is expensive to pay for people to isolate and quarantine, just think about the costs of them not doing so.
Thank you very much, Stephen. And thank you for that question. We'll now move on to Rose Matthews. Rose, are you here?
Yes, I'm here. Thanks very much indeed. The question that I wanted to ask is, as restrictions continue to ease, how can people like me who've been restricting their activities for such a long time resume contact with other people confidently? I'm actually about to start a new part-time job on Monday. This will be my third attempt to start a new job since the beginning of the pandemic. I'm autistic, so transitions at work are always particularly challenging for me. And obviously, COVID adds an additional dimension to this. And specifically, I'll be working outdoors, having brief contact with groups of secondary school children. Is it overly cautious of me to want to wear a face mask at work, or is this a sensible precaution to protect myself and other people? Thank you.
Thank you very much, Rose. So quite a specific question, and Professor Susan Mickey is going to answer it.
Excellent question. We know that transmission outdoors is much, much less risky than indoors. Something like more than 20 times the number of infections, COVID infections, happen indoors compared to outdoors. Having said that, if you're outdoors and you're within 2 meters of somebody who has COVID and they happen to cough, sneeze, even shout loudly or sing in your direction, then there is a chance that some of the virus may find itself on your eyes, in your mouth, or in the mucous membranes of your nose, which is where the virus does like to get in. So I think I don't think you should feel it's overly cautious to wear a face mask, because it sounds like you may be coming into contact with people within that kind of range.
Thank you.
Thank you very much, Susan. Does anybody else want to comment on this? I think that was a fairly straightforward question in the end, but good luck with your new job, Rose.
Thank you very much indeed.
Moving on now to our next questioner, who is, I've got a couple to read out, but I might go to some live ones from the press first. So Chris McLaughlin from the Sunday People. Are you there, Chris? Oh, maybe he'll appear. I might read out one of my questions then. This one comes from James Fettinger, who says, why is the government not reviewing its roadmap after halting its vaccination rollout on March the 29th, the same day the stay-at-home rule ends? Surely this means the majority of unvaccinated under 49-year-olds will be socially mixing in the coming weeks or months as restrictions lift. So again, a question about how dates can be derailed by data or problems with the vaccination programme. Who'd like to take this? Apart from my puppy, Professor Christina Pargle.
So I think the first thing to say is that when the roadmap was released on the 22nd of February, there was no massive increase in vaccinations coming in April. So, the schedule was pretty much what it is now. So I'm not sure it would change the roadmap. I think what's more concerning is that cases have stopped dropping. And so that is kind of what I'm looking for. Like, what are they going to do, particularly if they do start going up a bit like we've seen in Scotland? Then does that change? And I think what worries me is that it won't change things and we'll carry on opening up, even though R will have gone above 1, in the same way that Scotland is continuing opening now. So that is more of a worry. I don't think it needs to be tied into vaccinations. You can open safely as long as you put the measures in place, but we haven't done that and we're not doing that. So given that they are only relying on vaccinations, that's the worry to me.
Thank you. And Zubaida, you had a response to this question.
Well, yes, I was going to say, this is the biggest problem, that the government are putting all their eggs into one basket. The approach to testing, which was absolutely crucial, the find, test, trace, isolate, and support, that's really missing, because at the moment, while the government is saying that they've got testing, it's testing without supported isolation, and worse, in schools, it's utterly haphazard. It's utterly haphazard. So we will have very little idea of what's going on in schools. At the moment, the only reason we have any idea is because the testing has been in schools. But from now on, from next week, it will be shifted to parents. And we know that once it gets shifted to parents, parents won't have to do the testing. They don't have to give consent. Children can still go to school without consent, and parents don't have to show any proof when they report the results. So it is haphazard. We won't know what's going on. There is no real testing system out there to make sure that the cases stay down. And I think the combination of the vaccination program, well, slowing down a little bit, but things opening up, schools, of course, have opened up, but no real measure to keep that down, means that there is a real worry that cases are going to escalate again very quickly.
Thank you very much. And now we're back to some live questions. So we will start with Greta Weaver from the East Midlands. Greta, are you there?
Hi there. Yes.
Hello, what's your question?
Thanks for having me. In light of the discovery of new, more infectious variants of the virus, and reflecting on the fact that so many of my NHS colleagues have died in the last year, why are Public Health England's infection control guidelines still advising health workers to use surgical masks and not fitted face masks when a patient's infection status is not known?
Thank you very much. So we know that other countries have updated their guidance on masks, particularly in response to the new variants. Why is that not happening here? Does anybody have any ideas? Gabriel, would you like to comment?
Well, I think it is the problem that we're HSE, as well as the Health and Safety Executive, as well as PHE, have responsibilities. PHE are there to provide some expert guidance on the matter, but it should be kept on under regular review. And indeed, mask wearing policy is changing around the world in response, particularly to the spread of the Kent variant. And we do need to take it into account. And I continue to be alarmed by the way in which we're not doing some of the fundamentals properly. We're not, as you say, reviewing our protective arrangements. We're not reviewing things like ventilation. For example, I've waxed lyrical about the New York Department of Education's approach to ventilation in schools. You could look up your child's school and your child's classroom online and find out what ventilation is like in that class. The HSE actually in England has a very clear statement about the importance of fresh air on its website, extremely clear. But I don't know anyone who's checking places of work anywhere in terms of making sure that the ventilation is adequate. And we're just not handling all of these infrastructural stuff properly. Why not? Well, because it's very interesting. I've developed a real dislike of a phrase, and I know I'm not the only one who dislikes it. Non-pharmacological interventions or non-pharmaceutical interventions. And it's very frequently used by the government as a way of dismissing things that don't come out of the sort of medical industrial arena, and really practical things like ventilation, like mask wearing, like even distancing. We've never gone back to 2 meters as the standard. It was dropped last summer, has never been reintroduced, and we're just not doing the fundamentals right. And now I can't explain why the government has not done these things, but they haven't done them for over a year, and I don't expect them to start soon. So someone else has to take control of this, and I think trade unions and professional organizations need to step up to the plate and look after their members. Because, as you say, with the variants, some of them certainly far more infectious and some of them potentially more lethal. And we absolutely do need to do more to protect workers' health.
Thank you very much, Gabriel. And Greta, if I could just come back to you, I mean, how presumably your question comes from a perspective of thinking that actually you should be wearing higher grade PPE at work.
I know I've been following the work of Tricia Greenlaw for a while, and I know that she talks a lot about airborne infections, and I know that surgical masks are they leak airborne virus out as well as not protecting the workers as well. So it's kind of both ways. That's why. sort of concerns me. Yeah.
Alice, could I just come back on one thing? You're quite right, Greta, about the importance of airborne. And I was amazed, having had my first vaccination. As I left, I was given a leaflet about vaccination, and I turned to the back page of that leaflet, and the spiel that is there about the spreading is all about droplets. It doesn't mention airborne. It talks about droplet spread.
And vaccinators were wearing surgical masks, and we were really close, and I was concerned about them.
I do think that some of these fundamentals are not being done properly at all.
Steve Reischer, you'd like to comment too?
If I could just broaden it and carry on from where Gabriel left off about the fact that this is really a very broad issue of safety and doing the basics right on safety. And Independent Sage, way back in the autumn, was talking about reopening workplaces safely and the importance to have procedures, I mean, of all sorts, in order to make sure that people with confidence could go back to workplaces, and those workplaces were safe. And I was looking into this a bit this week and found some really interesting research which shows that over 70% of people don't feel safe about going to a restaurant if and when restaurants are reopened. That more seriously, over 70% of people don't feel safe going back to work, any workplace, if there aren't clear and certified health and safety procedures in place. And that over 95% of the population, in other words, basically all of us, would feel far safer and far more confident if there were universal and clear standards to ensure that places are safe. Now, we called for the government to institute a process working with local authorities of certification, whereby local health and safety and local inspectors could go round, could give advice, could give support, could give help, such that workplaces, hospitality and so on were safe. And that was never done. And the interesting thing is that looking around, I found a huge number of sort of independent attempts. Everybody from the AA to the construction industry to cleaning industries are beginning to bring in their own certificates. Now, that's because they recognize how important this is, not only in terms of safety, but in terms of confidence and getting people out into the economy when we reopen. The only people who don't seem to realize the importance of this are the government. And of course, it would be far better if it was done universally, not an ad hoc set of measures, and people would have far more confidence if it was made compulsory, so that we can go into any workplace, that we can go into any hospitality, into any hotel and see a sign up on the window saying this is COVID compliance. It's a really basic thing. It's a really important thing, and it's not being done, and it needs to be done.
Thank you very much, Stephen. And Professor Christina Pargle, you want to squeeze in here? You can.
I do. So two things. The first is that, as you say, other countries have upgraded their requirement on masks, not just in hospitals, but they have the proper protective ones, but also for the public, asking them to have better quality masks as well. And they're even paying for it in some countries. And it's just one of these, it's quite a simple thing to do, and yet we're not doing it. And I just feel like it's all part of this unwillingness to learn and unwillingness to change, even in the light of better evidence. And secondly, things like investing in safer workspaces, investing in better ventilation systems, that's not just good for COVID, right? That will pay dividends in years to come. It will help reduce flu infections year on year. It will help reduce any kind of respiratory virus. Having better air quality is a good thing, right? So that kind of investment, it's not a short-term thing, it's a long-term thing that has long-term benefits way beyond just this pandemic. And so I find it just unbelievable that we're not taking advantage of this moment to really push it through.
Thank you very much, Christina, and Greta. Thank you very much for that question. Moving on now to another question coming from Jane Mace in Herefordshire. Jane.
Hi.
What's your question?
What do you think the government's current COVID strategy actually is? Do you think they are trying to push the rates as low as possible through a combination of vaccination and changes to testing, and then potentially announcing that zero COVID might be possible after all?
Thank you very much, Jane. It's been a question that's been discussed at length on Independence Age briefings over the weeks and months. Susan, what do you think the strategy is?
I think you have to draw the conclusion from all the measures that the government have and haven't done, that the strategy isn't one of maximum suppression, isn't one of driving down to zero COVID. So we have minimal, if any, community transmission and a very good test, trace and isolate system that can jump on any outbreaks if they are to occur. But instead, what it is to just contain the virus so that it doesn't overwhelm the NHS. That seems to be their main criterion. And there seems to be an acceptance of not putting the investment into the measures that are needed to drive it down towards zero COVID and allow it bumbling along at a level that they think is all right, and a number of thousands of deaths a year that they think will be publicly acceptable. But the problem about this strategy, I've heard it's, the analogy of a fire, in your house. You can have little embers glowing around the place without a system to put it out when it flares up. And it's going to carry on being a problem. There's no way that that is a successful strategy. And we know that the alternative strategy of driving down towards zero COVID has been pursued really successfully, both in terms of saving thousands, tens of thousands of lives and of protecting the economy in pretty well all continents. Whether it's New Zealand and Australia, whether it's Uruguay and Cuba in Latin America, Kerala in India, Norway and Finland in Europe. So it can be done. But I don't see any signs of the government changing the current strategy, sadly.
Given the evidence around the world from those countries that have done maximum suppression and have emerged the best so far, I mean, we're still in the pandemic, but they've been doing the best of any of us so far. Where does this ideological resistance to that come from? That's something that I've found very confusing. Does anybody have any idea about where that comes from? Because it doesn't seem to be evidence-based. I'm not sure what it is.
I mean, the other whole important part of the world that I failed to mention is China and Southeast Asia. And there you have countries that are really different in terms of the type of government and the type of society, from China to Singapore and South Korea. But they share a similar perspective. And I think in that part of the world, they have had experience of SARS and they know what needs to be done. I think here you've got a combination of on the one hand, a lack of experience and an unwillingness to learn from other countries who do have that experience. But also I think what we've seen is a putting business above public health. And I think that's been incredibly well demonstrated with putting the test, trace and isolate system into the hands of big commercial companies. And I think it's £36 billion and rising. Spent on a system that doesn't work, instead of building up the public health infrastructure that we know, when it does have the resources to do that work, has done exceptionally well. So I think there's a bit of a clue in my answer to the reason.
Thank you very much, Susan. And of course, it's not all businesses. I mean, many businesses have suffered badly through the choice of strategy, if we can say there is a strategy in place. Gabriel, you wanted to comment as well.
Well, it is a most interesting question. It's clearly not based on a pure position on the political spectrum. Some of the countries that have done best are on the right, some are on the left. That doesn't seem to me to be part of it. Some of it, as Susan said, is a prior experience of related issues. And that then makes me think it's to do with their systems and their public health systems. I think it's two things. First of all, that issue of the public health systems is extremely important. The UK has effectively demolished its public health system over the past decade and reduced it in priority, reduced it in importance, reduces its funding, its staffing, everything about public health protections has been diminished. So it wouldn't be therefore, and you know, we came into this pandemic in the midst of a public health crisis with a stalling of this century-old improvement in life expectancy in this country. I mean, an astounding situation where the life expectancy was actually falling for some people, particularly women in our worst off communities. Astounding position to come into a terrible public health crisis with a diminished public health system and the health of the population getting worse at the same time. So something to do with the position that they are in respect to public health. And then the extent to which the dogma of it has to be a choice between economy and health carries weight. And I think if the pandemic's done one thing for us in policy terms, it's made perfectly clear that these are not opposite poles, that you cannot have a healthy economy without having a healthy population. You can't have healthy high streets without having healthy side streets. That has demolished that. But some countries have still not accepted that. And some countries, unfortunately, are still giving a lot of credence to particular lobby groups, for example, the international airline companies or leasing companies or whatever, seem to me to have an enormous clout. And what worries me most, actually, is the way in which some of our major international organizations have responded. And it is one of the queries I have about WHO's response, their reluctance to do something about international travel, for example. And similarly, the European Commission recently wrote to 6 countries in Europe, including Germany and Finland, doing quite well, doing really well, actually, some of them in terms of COVID, telling them off because they had the audacity to put border controls in place. So there is a real problem in terms of getting to the position where we don't regard the economy and health as opposite poles. And then also this linked issue of the strength of the public health infrastructure in countries and internationally.
Thank you very much, Gabriel, and thank you for that question. I'm going to squeeze in one last question from Margaret Ehrenberg in Worcestershire. Margaret, are you there?
Hi, thank you. Yeah, I mean, we've largely covered this question, but my observation was that with us supposed to be opening up in 3 weeks' time, middle of April, and I was looking at the figures for the same point at the end of July last year when gyms and shops were opening, the figures are still about 5 to 7 times as high as they were then. Does this make it seems to me it's quite worrying that we're thinking of opening up? Are vaccinations supposed to be making all the difference?
Thank you very much, Margaret. Christina, can I pass that question over to you? You know, are we at a point where cases are low enough, really, to be opening up?
Well, you can't. It's hard to compare directly to last summer because our testing landscape is so different now. And you know, the things are different. We have a different variant that makes things worse, and we have vaccinations which will make things better. So, I mean, is it the right time to open up? I actually think you probably can open up outdoor spaces, which is what we are doing to begin with. So I don't really have a problem with that. I do have a problem with the fact that we have open schools and we haven't tried to make them safer. I mean, that's just something that I don't understand. We haven't made workplaces safer. We haven't done the borders. We've had 8-9 months where we've known that these things will help keep cases down to not just the low levels we had last summer, but lower levels, really low levels. And we just haven't put any of those mechanisms in place. And we don't seem to, well, I say we, the government doesn't seem interested in doing that. So yeah, I mean, I don't have a better answer than that, I'm afraid.
Thank you very much. But I think your answer was really important because it shows that it's not a black and white choice between keeping lockdown and opening up. We can open up with mitigations in place and perhaps not enough focus on those mitigations. Does anybody else want to respond to Margaret? Kit?
So I think Christine is absolutely right to say that we're in a very different situation to where we were last year. We have got vaccinations now, but the problem for me is that I think going back to the previous question, the government strategy seems to be largely focused around vaccinating our way out of this and getting people vaccinated as quickly as possible, and forgetting about all the other things that we should be doing, like making workplaces safe, like making schools safe, like getting a functioning find, test, trace, isolate system, which means that if we do get cases low enough that we can start to stamp on outbreaks. There's a paper that was released in the last couple of days from the University of Warwick, a modelling paper, which suggests that even if we get extremely high vaccine coverage of all the adult population, that might still not be enough to bring the reproduction number below 1, which obviously is a worry, because it means that cases will continue to rise. So, clearly vaccination is not the whole way out of this. And we need to be thinking about the other measures that we can be doing to try to keep on top of cases and therefore hospitalizations and further deaths from this disease.
Thank you, Kit. Zubaida, you'd like to say something here?
Just very quickly, I think the other issue is young people won't be vaccinated, or at the moment, we don't know if they will be vaccinated. And that's approximately a fifth of the population. And quite honestly, if you break that down by ethnicity, it's much higher for some groups. So we know for Asian groups, it's about a quarter of the population who are under the age of 18. We know for mixed ethnicity groups, it's about half of the population who are under 18. So we've got a fifth of the population that won't be vaccinated, that will still be exposed to this virus. And if the virus level remains high, that has huge consequences for those groups, including long COVID. We know that actually it can still severely affect some children. There has been hospitalizations of children. So there is a real emphasis and onus and responsibility here to keep that virus down. We have to think about the people who won't be vaccinated, especially young people.
Thank you very much, Zubaida. Susan, you could have a quick word.
Just to sort of I suppose balance it, that this isn't absolutist. I don't think we should be saying young people won't be vaccinated, certain communities won't be vaccinated. I think there'll be smaller proportions, but it shouldn't mean that we don't keep on trying to do whatever we know works to get the maximum vaccination rates in those groups. And we know that where people from those communities have taken an active role in two-way discussions about people's questions, about people's concerns, people's fears, then the interest and the uptake of the vaccination has increased. So I think we need to, not kind of give up at this stage, say it's going to be difficult, but even more important than ever, to draw on the evidence of what we know works to help maximize the vaccination, because that is going to be so key.
Thank you very much. Well, I really am going to have to bring it to a close. So David, would you like to say a few words?
All I wanted to say was to add to the answers just given. The time to lift lockdown is that moment when we are separating people who have the disease and those who've been in contact with them from the healthy members of the population. And if you don't wait until you've got to that point, and there should be a point where the number tested and so on, the number isolated and so on, equals at least the numbers who are going down with the disease. When you get to that point, yes, you can lift the lockdown. That's the sharpest way to deliver a good lockdown with no risk of a new wave.
Thank you very much to David. Thank you very much, everybody on Independent Sage. Thank you to everyone who's brought questions along today. What a fantastic range of questions, a range of content that we've covered. Thank you to everybody watching as well. A year into the pandemic, it looks like we can clearly see light at the end of the tunnel, but Independent Sage will continue to hold these weekly briefings until coronavirus poses no further significant threat to us all. We need access to information. We need dialogue between scientists and the public. All our reports are on the website, along with details of all the scientists. Please follow Independent Sage on Twitter and Instagram as well, if you don't already. And we'll be back, same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everybody.
Thank you.
Thank you. Bye all.